Welcome to the Hospital Medicine Unplugged podcast.
We are diving deep today into really one of the fastest moving, most life-threatening infections we face on the hospital wards, ascending cholangitis.
Absolutely. This is an acute, often fulminant infection of the biliary tree. And, its clinical importance cannot be overstated if recognition and critically treatment, especially getting that source control, are delayed.
Which happens too often.
Right. Patients can rapidly progress to overwhelming sepsis, multi-organ dysfunction, and frankly, alarmingly high mortality rates.
It really is a time-sensitive emergency. I mean, historically, before we had modern medicine, before effective biliary drainage techniques, mortality for acute obstructive cholangitis was near 100%.
Wow.
Yeah. Today, while we've improved significantly, severe cases, those with systemic compromise, they still carry mortality rates that can exceed 10%, sometimes even 15%. This is a disease where truly minutes matter.
Okay, so our mission today for you listening is to provide a highly structured, evidence-based roadmap for managing this emergency. We're focusing specifically on the hospitalized patient, either presenting with it or maybe rapidly deteriorating from it.
Exactly. What is absolutely critical to know and do right now.
And that roadmap, it's built entirely on what we're calling the core triad of management.
It has to be implemented simultaneously, almost flawlessly. You've got prompt supportive care, aggressive resuscitation.
Step 1.
Then early empiric IV antibiotics to try and stabilize the patient.
Step 2.
And step 3, the defining feature of management, timely biliary decompression. That's the source control.
Getting the timing of those 3 wrong, that's what separates a stable patient from a septic catastrophe.
Absolutely.
Okay, let's start at the beginning. The mechanism of infection. We hear the term cholangitis, we know it's an infection, but what actually happens in the biliary system? How does a simple blocked duct turn into this systemic septic crisis?
It really all comes down to fluid dynamics and pressure. The fundamental trigger always is biliary obstruction.
Some kind of blockage.
Right, whether it's a stone, a stricture, a mass. When the common bile duct gets blocked, it leads directly to biliary stasis.
And the stasis itself is the problem, because bile is normally flowing, right? It's like a natural flushing mechanism.
Precisely. Bile actually has some inherent antimicrobial properties, but when that flow stops, the normal resident flora, the bacteria that have ascended retrograde from the duodenum,
climbed up from the gut.
Yeah, exactly. They start to colonize and multiply rapidly within that static bile inside the biliary tree.
But the real danger, the part that leads straight to sepsis, isn't just the infection sitting in the ducts, it's the pressure building up, isn't it?
Exactly. That obstruction causes a catastrophic increase in the intraductal pressure. Normally, duct pressure is pretty low, maybe around 5 to 10 centimeters of water. Yeah. When you get a complete block, that pressure can spike way up, 20, 30 centimeters of water, sometimes even higher. And it's this massive hydrostatic pressure gradient that literally forces the bacteria and their toxic byproducts, especially the endotoxins from gram-negatives, to translocate.
Translocate where?
Across the compromised biliary epithelium, basically squeezing through the duct walls.
So it's almost like a burst pipe, forcing bacteria directly into the portal circulation, and then boom, systemic circulation.
That's a perfect analogy. That translocation immediately kicks off a widespread systemic inflammatory response that leads to bacteremia, the clinical syndrome of sepsis, and ultimately multi-organ dysfunction.
And the higher and longer that pressure stays up,
the more profound the systemic insult. It's a direct relationship.
That really highlights why source control is just paramount. You can't fix the sepsis until you relieve that pressure.
You got it. Now, thinking about what causes this critical biliary obstruction, we have to identify the etiology quickly because that really informs our management. Yep. The leading cause, particularly in Western countries, it's still choledocholithiasis, common bile duct stones. They account for the vast majority of cases we see.
Makes sense. What about other significant culprits? What if the imaging, say, doesn't show stones?
Then we immediately start thinking about benign or malignant biliary strictures. On the benign side, maybe chronic pancreatitis causing scarring and narrowing, or sometimes post-surgical changes.
Okay.
But malignantly, and this is often more worrying, we're talking about things like pancreatic head cancer, compressing the distal common bile ducts from the outside.
Right.
Or primary ductal tumors themselves, like cholangiocarcinoma. Malignancy-related obstruction is particularly concerning because it tends to be a higher grade blockage, and it's associated with worse outcomes overall.
And for our hospitalized patients, the ones already in the system, we always have to consider iatrogenic causes, right? Healthcare-associated factors.
Oh, absolutely. These are crucial differentiators. Any patient with a history of prior biliary instrumentation, sphincterotomies, or especially the insertion of biliary stents or drains,
Yeah.
particularly if those stents are known to recurrently block, they're at elevated risk. These interventions can introduce resistant bacteria, or they might permanently compromise the integrity of the sphincter of Oddi, making them sort of inherently susceptible to ascending infection down the line.
So that history really guides our thinking, especially maybe towards which antibiotics to pick first.
Exactly. It pushes us towards considering broader coverage, which we'll definitely get into. That link between prior intervention and current infection is a key clinical pearl to keep in mind.
All right, so moving to clinical presentation. We have to kind of reconcile the classic textbook picture with the reality of what we actually see at the bedside.
Yeah, it's a huge point.
The classic sign we all memorized is Charcot's Triad: fever, jaundice, and right upper quadrant pain. It sounds neat, but the sources really emphasize its fundamental limitation.
It's highly specific, meaning if you actually see all three, you can be pretty darn confident in your diagnosis.
Yeah.
Specificity is often reported over 90%.
Okay, so if it's there, it's likely cholangitis.
Right, but, and this is the big but, its sensitivity is terrible. The literature suggests Charcot's Triad is only present in about maybe 1/3 of confirmed cholangitis cases. Sometimes studies show it as low as 20%.
Wow, only 20, 35%. So relying on seeing the full triad, that's a recipe for missing the diagnosis in, what, 2/3 of patients?
Exactly. It's a fantastic rule-in test if you see it, but it's a disastrous screening tool. You just can't use its absence to feel reassured.
So if we see, just say, the classic pain and fever, we have to act immediately, even if jaundice hasn't developed yet.
Absolutely. Don't wait for the yellow. And speaking of severity, the even more frightening constellation is Reynolds-Pentad.
Right, which layers on the really systemic signs of severe sepsis.
Yes. That's Charcot's Triad plus hypotension and altered mental status.
Okay, that sounds bad.
It is. If you encounter a patient with Reynolds-Pentad, you are dealing with profound septic shock secondary to cholangitis. That patient needs the ICU, probably pressors, and immediate urgent drainage.
The good news, I guess, is that it's rare.
Yeah, very rare. Sensitivity is less than 5%. But when you see it, it's a marker of imminent multi-organ failure. No time to waste.
Okay, so beyond these classic, but as we said, limited signs, what should we be focusing on during the physical exam? Thinking particularly about the IDSA recommendations for severe sepsis syndromes.
We focus on two things: systemic inflammation signs and localized findings. Locally, it's still tenderness in the right upper quadrant. Often you might find rebound or guarding, suggesting more severe inflammation, maybe even localized peritonitis.
Okay.
Systemically, we're looking for signs of volume depletion and the body trying to compensate. So marked tachycardia is a big one. Fever, obviously.
And what about jaundice itself? How reliable is that?
Well, jaundice can be subtle. We should always check the eyes for scleral icterus. The yellowing there is often detectable earlier than skin jaundice.
Good tip.
But remember, the absence of jaundice doesn't rule out the disease, especially if the obstruction isn't complete, or maybe the infection is just starting.
Right.
This brings us to what might be the most critical clinical takeaway here: the danger of atypical presentations. Who are the patients who won't present with that neat textbook picture, and how do they fool us?
Yeah, this is where we get into trouble. The elderly and the immunocompromised are the classic exceptions. They often have a blunted or impaired inflammatory response, meaning they might lack fever entirely, or the only sign might be mild hypothermia, which is just as concerning. They might not generate enough systemic inflammation to have that profound, localized RUQ pain.
So instead of the classic triad, what are we seeing in these vulnerable patients?
Their presentation is often frustratingly non-specific. It's easily mistaken for other common things in the elderly. Think generalized weakness, maybe failure to thrive, new onset confusion, or delirium.
Delirium is a big one.
Huge. Or unexplained falls, new incontinence, or just a subtle but rapid functional decline. They're clearly systemically ill, but they lack those specific localized signs we're often conditioned to look for. And that subtle presentation, the confusion, the falls, that's profoundly dangerous because it leads directly to diagnostic delays. Right?
Absolutely. The clinical takeaway here, the thing you really need to burn into your brain, is this. If an elderly patient, especially one with known gallstones or any history of biliary intervention, suddenly develops new confusion or any subtle sign of decline, cholangitis must be high on your differential diagnosis. even without the classic Triad.
Don't wait for the textbook picture.
You cannot wait.
Mhm.
That delay is directly associated with increased morbidity and mortality in these populations. Hashtag TEG3. Diagnostic evaluation and severity grading. TG22.
Okay, so to structure our approach and avoid those delays, we use the Tokyo guidelines, specifically TG22. They provide this multimodal diagnostic and stratification system. Diagnosis needs clinical suspicion, but it's really supported by lab work and imaging. Let's start with the labs. What are we hunting for in the blood work?
We're essentially looking for two major categories of findings. First, evidence of systemic inflammation. Second, evidence of cholestasis or hepatic injury from the backup.
Okay, inflammation first.
For inflammation, we look at the WBC count, the white blood cell count. It's usually elevated, sometimes significantly. And the literature suggests that a really pronounced leukocytosis, specifically a WBC count over, say, 20,000 per microliter, that's a red flag. It independently suggests a higher risk of bad outcomes and greater severity.
Got it. WBC 20K is bad. What else for inflammation?
We also look for marked elevations in CRP, the C-reactive protein. It's another key inflammatory marker.
Okay, makes sense. Now, the cholestatic picture. What confirms the blockage?
Right, this tells us bile flow is obstructed. We look for elevated alkaline phosphatase, often called ALK-Phos and GGT. These are enzymes that tend to rise specifically when bile flow is blocked.
Okay.
And then the liver transaminases, AST and ALT, they'll usually be elevated too, often more than 1.5 times the upper limit of normal. That indicates some hepatocellular injury, likely from the pressure buildup.
And crucially, we track the total bilirubin. What's the significance of that level, according to the guidelines?
A total bilirubin greater than 2 milligrams per deciliter is actually required to meet the formal diagnostic criteria for cholestasis in this context.
Okay, so 2 milli-GDL is part of the definition.
Yes. But when you see that level climb above 10 milli-GDL, that's a specific marker of severity and generally indicates a poor prognosis. It suggests not only a complete or near complete obstruction, but also significant functional impairment of the liver's ability to conjugate and excrete bile.
Got it. Bull-Dia is another major red flag. Okay, so once we have the lab suggesting inflammation and cholestasis, imaging comes next to confirm the obstruction and hopefully identify the cause. What's a logical kind of stepwise approach here?
We usually begin with abdominal ultrasound, or US. It's quick, it's portable, non-invasive, no radiation, and it's excellent for detecting ductal dilation. That dilation is the key sign of obstruction we're looking for.
And it can see stones, too.
Yeah, it's also very good for identifying the presence of gallstones, which, as we said, are the most common cause. So US is often the first and best test.
But what if the US is equivocal? Maybe the patient's body habitus makes it difficult, or there's too much bowel gas, or it just doesn't clearly show the cause. Where do we go next?
The next logical step is usually a CT scan, typically with IV contrast. CT provides much better anatomical detail, especially when we're suspecting something like a mass or a stricture, that pancreatic cancer, cholangiocarcinoma, compressing the duct.
Right.
It's also helpful for ruling out other non-biliary causes of abdominal pain that might mimic cholangitis.
Okay, so US first, then CT if needed. What if we need even more detail, maybe the most exquisite detail of the ducts, but without doing an invasive procedure yet?
That's where MRCP, magnetic resonance cholangiopancreatography, comes in. It uses specific MRI sequences, heavily T2 weighted, to essentially create a non-invasive map of the entire biliary and pancreatic ductal system.
Like a virtual ERCP.
Kinda, yeah. It has the highest sensitivity for identifying small stones that maybe the US or CT missed, or complex strictures, and other subtle pathology. And it does this without the risks associated with an invasive procedure like ERCP.
Okay, that makes sense. So we have the clinical picture, the labs, the imaging. Let's formalize the diagnosis now using those Tokyo guidelines, 2022, TG22 criteria. How do they separate suspected from definite cholangitis?
Right. The criteria are structured into 3 main categories. A, systemic inflammation signs. B, cholestasis labs. And C, imaging findings showing obstruction or cause.
Okay.
Suspected cholangitis requires only one item from category A, like fever or elevated WBC, and D, one item from either category B, like elevated bili or ALK-Phos, or category C, like ductal dilation on US. So it's a lower bar.
For example, fever plus elevated white count, or RUQ pain plus biliary dilation on ultrasound.
Exactly. That gets you to suspected.
And to achieve the highest certainty, definite cholangitis, what's required then?
That requires meeting criteria more rigorously. You need one clinical item from category A, the inflammation signs. AD, you need evidence from all of the following: lab evidence of systemic inflammation, like elevated WBC or CRP, A&D lab evidence of cholestasis, like elevated bilirubin or alphos, A&D imaging evidence of biliary obstruction or its underlying etiology.
So definite requires proof of inflammation, proof of cholestasis, and proof of obstruction on imaging, plus a clinical sign.
Precisely. It confirms the whole picture. The blockage, the resulting inflammation, and the infection.
This systematic approach is vital because it leads us directly to the severity grading. And this absolutely determines how quickly we need to intervene, right? Let's dissect the TG22 severity grades, grade 1, grade 2, and grade 3.
Yes, we must use this grading system at the bedside. It literally sets the timeline for source control. You have to assign a grade.
Okay, starting with grade 1, mild. What defines that?
Grade 1 patients meet the criteria for definite cholangitis. But crucially, they have no evidence of organ dysfunction. And they don't meet any of the specific criteria for moderate disease either. They're generally hemodynamically stable, maybe just febrile with RUQ pain and some lab abnormalities.
And the management for grade 1?
For these patients, we initiate supportive care fluids, pain control, and broad-spectrum antibiotics. Then we monitor them very closely. If they respond rapidly, meaning fever resolves, pain improves, labs start trending down, we might be able to defer drainage, or in some cases maybe avoid it altogether if it was, say, a small stone that passed. But drainage is still generally preferred for definitive resolution.
Okay. Now, grade 2, moderate. This moves us into the realm of needing early intervention. What distinguishes a grade 2 patient?
Grade 2 means the patient has signs of increased local or systemic severity, but they haven't yet progressed to full multi-organ failure. The criteria here are specific and include things like a very high fever, defined as over 39 degrees Celsius or 102.2 Fahrenheit. Marked hyperbilirubinemia, specifically bilirubin of 5 milligdl or higher, but importantly less than 10 milligdl. Advanced age, defined as 75 years or older, or marked leukocytosis, a WBC count over 18,000, or significant hyperalbuminemia.
So meeting any one of those bumps you to grade 2?
Correct. If you meet the criteria for cholangitis plus any of those moderate severity factors, you're grade 2. And these patients require early biliary drainage.
Define early.
Early generally means the procedure, usually ERCP, should be planned and executed typically within the 48 to 72-hour window from diagnosis.
Okay, 48, 72 hours for grade 2. Now, grade 3, severe. This is the patient we're rushing to the ICU, right? And calling the GI team immediately.
Absolutely.
Yeah.
Grade 3 signifies septic cholangitis. It means the patient has the presence of organ dysfunction in at least one system. Essentially, they meet the definition of septic shock or severe sepsis triggered by the biliary infection.
And the TG22 criteria are very specific here.
Extremely specific. For cardiovascular dysfunction, it's hypotension requiring vasopressors to maintain perfusion. For neurologic dysfunction, it's any altered mental status compared to baseline. For respiratory, it's a low PaO2-FiO2 ratio indicating hypoxemia. Renal failure is acute kidney injury, AKI, defined by specific rises in creatinine or drops in urine output. Hematological dysfunction includes an INR greater than 1.5.
Suggesting coagulopathy or liver failure.
Exactly, or a platelet count dropping below 100,000 per microliter.
So the presence of any one of those organ dysfunctions immediately upgrades the patient to grade 3.
Correct. Cholangitis plus any organ failure, grade 3 severe. These patients cannot wait 48 or 72 hours. They require urgent biliary decompression.
And urgent means?
Often meaning within 12 hours of making that grade 3 diagnosis. Many experts, myself included, would push for intervention in less than 6 hours if it's technically feasible and the patient can be safely transported for the procedure. Any delay in these unstable patients dramatically increases the risk of irreversible organ damage, especially AKI and worsening liver failure. The clock starts ticking the moment those grade 3 criteria are met. Hashtag tag AVIV nouns. Microbiology and empiric antibiotic selection.
Okay, let's shift focus now to the bugs themselves, the infectious agents. Given the origin of the infection ascending from the gut, the infection is almost always polymicrobial, involving multiple types of bacteria, correct?
That is correct. You rarely isolate just one organism. In a typical patient presenting with their first episode of community-acquired cholangitis, the primary targets, the usual suspects, are gram-negative enteric bacteria. We're talking about organisms like E. coli, Klebsiella species, and Enterobacter species. These are the workhorses of the gut flora, and by far the most common culprits found in initial bile cultures.
But the sources really stress that we cannot just focus on gram-negatives. We have to worry about gram-positive organisms too, which seem to be becoming more prevalent, especially in complicated cases.
Absolutely. We must be vigilant for enterococci species. Their prevalence has really risen significantly over the last couple of decades.
Why is that?
It seems to be associated particularly with patients who had recurrent disease, multiple prior biliary interventions like stenting, or existing biliary hardware. While enterococci faecalis is maybe more common and generally more susceptible.
Okay.
We also have to consider the possibility of the more intrinsically resistant enterococci faecium, especially in very sick or previously treated patients. Our empiric antibiotic choice needs to adequately cover these gram-positives, especially if the patient profile fits that high-risk picture.
And then there are the even higher risk or nosocomial pathogens, the ones that might sneak in, particularly in the healthcare-associated setting or with indwelling devices.
Right. For any patient with biliary prostheses like stents or drains, or someone with a prolonged hospital stay before developing cholangitis or recent instrumentation, we absolutely must extend our empiric coverage to include Pseudomonas aeruginosa. It loves plastic.
Good point.
And then for the truly critically ill, the profoundly immunocompromised, or those who have had lots of previous broad-spectrum antibiotic exposure, we occasionally need to consider fungi. Fungal pathogens, specifically Candida species, potentially co-infecting the biliary tree.
Okay, so a complex mix of potential bugs. This leads us directly to the threat that really governs our initial choice of therapy, multi-drug resistance, or MDROs. How do we quickly risk stratify for MDROs at the bedside when we first see the patient?
Recognizing the risk factors is paramount because it dictates whether standard empiric therapy is likely to work. The major predictors for MDROs, we're talking things like ESBL-producing organisms, or even worse, carbapenem-resistant strains, include advanced age, having a prior biliary stent placed, having had a previous sphincterotomy.
Okay.
And perhaps most importantly, a history of repeated ERCPs or extensive recent antibiotic exposure, especially broad-spectrum agents. If a patient checks any of those boxes, our standard first-line empiric regimen might fail them.
Okay. So, on to the immediate intervention. Broad-spectrum IV antibiotics. These are non-negotiables, have to be started within the first hour of suspicion, ideally right after blood cultures are drawn.
Absolutely. Time is critical. For the typical community-acquired, lower-risk patient, someone who's maybe grade 1 or early grade 2, hemodynamically stable, no recent hospital exposure or major risk factors we just discussed, a common, effective first-line regimen is often piperacillin-tazobactam.
Zosyn, why is that the go-to?
Well, it provides excellent broad-spectrum gram-negative coverage, including Pseudomonas to some extent, and it also covers anaerobes pretty well. Plus, the tazobactam component protects the piperacillin from many common bacterial beta-lactamases, making it effective against typical community bugs. It also has some activity against Enterococcus faecalis.
Okay, so pick tazo for the standard low-risk case. But if the patient is high risk, if they have those known MDRO risk factors we listed, or if they're critically ill, say a grade 3 patient rolling in with septic shock, we have to escalate immediately, right?
Absolutely. That's when we need to pull out the bigger guns. We need to seriously consider the carbapenems.
Like meropenem or imipenem.
Exactly. If we have a high suspicion for ESBL-producing Enterobacteriaceae based on risk factors or local resistance patterns, or if the patient is just profoundly septic and failing to stabilize quickly, a carbapenem like meropenem is often necessary. It provides the broadest reliable coverage against resistant gram-negatives and anaerobes.
Okay. What if they have a severe penicillin allergy, like anaphylaxis? Can't use piptazo or carbapenems then?
Good question. In that scenario, we might consider a combination therapy, perhaps like a fluoroquinolone like ciprofloxacin or levofloxacin, plus metronidazole for anaerobic coverage. However, we have to be cautious because resistance to fluoroquinolones among gram-negatives is unfortunately quite common now in many areas. Aztreonam might be another option for gram-negative coverage in some allergy situations.
Right. Always check local antibiograms if possible. And critically, what about culture data? We start broad, but how long do we keep them on these big gun antibiotics?
Getting good cultures is key. Bile, collected during the drainage procedure, ERCP or PTC, is the optimal culture source. But blood cultures, drawn before antibiotics if possible, are also absolutely essential.
And then?
We keep them on the broad-spectrum empiric therapy until two things happen. One, the biliary obstruction is relieved, source control is achieved, and two, the patient is clearly clinically improving, meaning they are febrile, hemodynamically stable, inflammatory markers like WBC and CRP are trending down.
Okay.
Once source control is achieved and the culture and sensitivity data comes back, we should absolutely de-escalate. We transition to the most narrow-spectrum effective agent, either IV or oral, depending on the bug and patient stability, that covers the identified pathogen.
And the typical duration of antibiotics after source control, how long do they need them?
Generally, antibiotics are typically continued for only about 3 to 5 days after source control is successfully achieved and the patient is improving. Prolonged, indefinite courses are usually unnecessary if the underlying plumbing problem, the obstruction, has been definitively fixed. Okay, let's synthesize this now into the active management phase, really hitting home that core triad again. Resuscitation, then broad-spectrum antibiotics, then source control.
Resuscitation first. It's immediate, especially for the septic patient.
Immediate IV fluid resuscitation is absolutely essential. Patients with sepsis, particularly those with high fevers, may be vomiting, third spacing. They're often profoundly hypovolemic. We must prioritize hemodynamic stabilization with aggressive fluids.
And for those grade 3 patients, the ones who are hypotensive and needing vasopressors,
Rapid triage to a higher level of care, ideally the ICU, is non-negotiable. We're treating full-blown septic shock there. Fluids, pressors, potentially central access. So it works.
Okay, so resuscitate aggressively. Antibiotics on board within the hour. Then, once they're stabilized enough, the focus shifts immediately to the definitive treatment. Source control via biliary decompression. This is the non-negotiable step for pretty much everyone except maybe the mildest, most rapidly resolving cases.
Correct. Decompression is mandatory for all grade 2, moderate, and grade 3, severe cholangitis patients. It's also required for those grade 1, mild patients who, despite maybe 12 to 24 hours of maximum medical therapy, antibiotics, fluids, fail to show clear signs of clinical improvement.
Don't just sit on a non-improving grade 1.
No, you have to act. And what is the universally preferred method for achieving this drainage?
That would be ERCP, right?
Yeah.
Endoscopic retrograde cholangiopancreatography.
Yes. ERCP is the gold standard in most cases. It's preferred because it's generally minimally invasive compared to surgery, and crucially, it allows for simultaneous diagnosis and therapy. The endoscopist can directly visualize the lower end of the bile duct, see the obstruction, perform a sphincterotomy if needed to open the duct.
Cut the muscle.
Right, and then they can sweep out the obstructing stone with a balloon or basket, or place a plastic or metal stent across a stricture or blockage to bypass it and restore bile flow.
The literature seems exceptionally clear on the necessity of rapid timing for ERCP. Can you elaborate on that critical window?
Yes, the evidence here is incredibly strong, and this is perhaps the single most important clinical action point we'll discuss today. Multiple studies, including that key one in JAMA surgery we should mention later, clearly show that performing EOCP within 48 to 72 hours of diagnosis is directly associated with significantly lower rates of mortality.
Lower death rates.
Yes, and also reduced incidence of developing new or worsening multi-organ failure and shorter overall hospital stays compared to delaying the intervention beyond 72 hours.
Okay, so 48 to 72 hours is the standard target window for grade 2, moderate patients. What about those truly critical grade 3 patients, the ones in septic shock? They can't wait that long.
No way. They need immediate urgent intervention. The TG22 guidelines state that grade 3 patients require drainage, ideally within 12 hours of that diagnosis being made.
Within 12 hours.
And as I mentioned, many experts, and certainly in practice for very unstable patients, we push for intervention in less than 6 hours if it's technically feasible and the patient can tolerate getting to the endoscopy suite or IR. Any delay in these unstable patients just keeps fueling the fire, increasing the risk of irreversible organ damage, especially that dreaded API and worsening hepatic failure.
Okay. This raises a practical point, though. ERCP isn't risk-free, right? Post-ERCP pancreatitis is a known complication. When might we hesitate? Or what are the necessary alternatives if ERCP isn't the best option or fails?
That's an excellent point. ERCP does carry risks, primarily pancreatitis, but also bleeding, perforation, and infection. And sometimes it's just not feasible. If the patient has altered anatomy, maybe from a prior surgery like a Roux-en-Y gastric bypass.
Makes it hard to reach the ampulla.
Exactly. Or if the obstruction is extremely high up in the hepatic ducts near where they exit the liver, what we call healer obstruction, ERCP might be technically impossible from below, or it might carry a very high failure rate.
So in those scenarios where ERCP is out or it doesn't work, what are our main backup options for getting that bile drained?
The primary alternative is percutaneous transhepatic biliary drainage, or PTC. There's also endoscopic ultrasound-guided drainage, EUSBD, as a newer option in some centers, or less commonly nowadays, open surgical drainage.
Let's focus on PTC. How does that work?
PTC involves interventional radiology. They use ultrasound or fluoroscopy to guide a needle through the skin, through the liver tissue itself, directly into a dilated bile duct above the level of the obstruction. Then they pass a wire and place a drainage catheter that comes out through the skin.
So an external drain.
Yes, an external drain. PTC is generally reserved for when ERCP fails or is anatomically contraindicated, often used for malignant obstructions high in the biliary tree where ERCP can't reach or stent effectively.
What are the trade-offs between PTC and ERCP?
Well, PTC is effective at draining the bile, which is the main goal, but it requires puncturing the liver, so there's a risk of bleeding or bile leak, biloma. And having that external catheter can be uncomfortable for the patient, prone to dislodgement, and needs careful management. ERCP remains preferred when feasible because its internal drainage often allows for definitive treatment at the same time, like removing the stone, and avoids an external tube. But the bottom line is achieving drainage. If ERCP can't provide it quickly, PTC must be the immediate next step. Get the flow going. #tag6. Prognosis, monitoring, and complications.
Okay, so even after we've successfully achieved source control, these patients have been through a major septic insult. This remains a high-risk population. What are the major complications we need to actively monitor for in the aftermath?
The biggest worries are the systemic extensions of that initial septic process. We worry about progression to refractory septic shock despite drainage, or worsening or persistent multi-organ failure, cardiovascular collapse, acute respiratory distress syndrome, ARDS, and especially, as we've mentioned, renal failure.
Yeah, the sources really specifically highlight the high incidence and the prognostic significance of acute kidney injury, AKI, in this population.
Yes. AKI occurs in a surprisingly high percentage of patients with moderate to severe cholangitis, sometimes reported up to 18% or even higher. And it's a powerful, independent predictor of poor outcome.
Why is it so bad?
Well, it's not just a temporary issue from being dehydrated. The systemic inflammation, the endotoxin load associated with biliary sepsis, directly damages the renal tubules. Patients who develop AKI secondary to cholangitis have significantly higher mortality rates during that hospitalization. And even if they recover from the acute illness, they have a higher risk of long-term chronic kidney disease or decline down the road. Protecting the kidneys is paramount.
Got it. And locally, within the liver itself, any complications there?
Yes, we have to watch for local complications, like the formation of a liver abscess. This can happen from residual, undrained pockets of infected bile, or sometimes from bacteria seeding the liver parenchyma during the high-pressure phase. This requires aggressive follow-up imaging if the patient isn't improving as expected, and potentially further percutaneous drainage of the abscess itself.
Okay. Let's talk about prognostic indicators. Beyond the TG22 severity grade we assign initially, what other clinical or laboratory factors should really alert us at the bedside that this particular patient is at very high risk for a poor outcome, even after we intervene?
Any markers that suggest sustained poor tissue perfusion or an ongoing overwhelming systemic inflammatory burden are bad signs. This includes things like a high SOFA score, sequential organ failure assessment score, on admission or one that fails to improve.
Okay.
Persistently elevated lactate levels despite adequate fluid resuscitation, or hitting those extreme ends of the lab values we discussed earlier. A bilirubin that stays stubbornly above 10 mil DDL, or a WBC count that remains sky high, over 20,000 despite antibiotics and drainage.
Anything else?
Also, as we touched on before, if the underlying obstruction is due to malignancy rather than just a gallstone, that is consistently linked to worse outcomes. Likely because the malignancy often represents a more difficult, maybe incomplete source control problem, and these patients are often more debilitated baseline.
Right, and we keep coming back to the timing of intervention. Can we just underline one more time the impact of delaying that source control?
We really have to hammer this home. The evidence is just overwhelming. Delayed biliary drainage, often defined in the key literature, like that JAMA study, as waiting more than 48 hours after presentation for moderate or severe disease, is independently associated with a near tripling of the risk of death compared to getting drainage within that early window.
Tripling the risk of death.
Wow. Yeah. That delay essentially ensures sustained bacteremia and endotoxemia, prolonging the septic insult to all the organs and dramatically increasing the risk of developing persistent or irreversible organ failure. This is why aggressive early collaboration with your GI or interventional radiology colleagues is absolutely mandatory for grade 2 and especially grade 3 patients. It's a team sport and speed matters.
Okay, so let's say the patient is post-intervention, drainage is established, they're on appropriate antibiotics. How do we monitor their progress effectively while they're still in the hospital?
Monitoring has to be active and frequent, especially in the first few days. We need daily, sometimes even more frequent serial labs. We're tracking the WBC count, the CRP, and crucially following the liver function tests, bilirubin, alkwas, transaminases, and renal function, creatinine, BUN, urine output, to ensure they were responding appropriately to both the antibiotics and the drainage.
What should we expect to see?
We should see the bilirubin start trending down relatively rapidly once flow is restored. The WBC and CRP should steadily decline towards normal. Clinically, we're monitoring for the normalization of vital signs, resolution of tachycardia, resolution of fever, and also, importantly, the subjective improvement in their abdominal pain and mental status. And we have to keep re-stratifying their severity. If a patient who's grade 2 starts to deteriorate, they become grade 3, and the urgency might increase again.
What if that clinical improvement is slow or just doesn't happen? They have drainage, they're on antibiotics, but they're still febrile 48, 72 hours later.
Yeah, that's a major concern. If the patient is still significantly febrile or failing to improve clinically several days after supposed adequate drainage, we must suspect either inadequate source control or a complication. Meaning, maybe the initial drainage wasn't complete. Perhaps there are residual or migrating stones causing obstruction. Maybe the stent that was placed got blocked or dislodged. Or maybe they've developed a secondary complication like that liver abscess we mentioned, or even post-ERCP pancreatitis.
So what do you do?
This requires prompt repeat imaging, often a CT scan or maybe another ultrasound, to carefully reevaluate the biliary tree. Check the position and function of any drains or stents, and look for collections or abscesses that might require additional drainage or intervention. Don't just assume the first procedure fixed everything if the patient isn't getting better.
Makes sense. Finally, thinking about the long-term prognosis. We've stabilized the acute emergency, they've recovered, they're ready for discharge. What happens next to prevent this from happening again?
That's critical. The underlying etiology must be definitively managed to prevent recurrence, because cholangitis tends to recur if the root cause isn't addressed. If the cause was gallstones in the common bile duct,
Which is most common.
right, then the patient likely needs long-term surveillance, maybe repeat ERCP later for definitive stone clearance if it wasn't all removed initially. And importantly, if they still have their gallbladder, they generally need a cholecystectomy electively down the line to remove the source of future stones.
Okay. And if it was a stricture or malignancy?
If it was a benign stricture, they might need serial stenting or sometimes surgery. If it was a malignant stricture, they obviously require comprehensive oncologic workup, staging, and management, chemo, radiation, surgery, or palliative stenting. The key is close outpatient follow-up with both GI and possibly surgery or oncology to ensure definitive clearance of the obstruction pathway and to monitor for any chronic complications or recurrence. Preventing the next episode is just as important as treating the first one. #outro.
This has been a really necessary and critical deep dive into ascending cholangitis. It's a disease just defined by urgency. To quickly summarize our evidence-based roadmap for everyone listening.
Okay, first, develop that keen clinical eye. You have to recognize the atypical presentation, especially in the elderly or immunocompromised. They might just show up with confusion or functional decline. And please, abandon reliance on the low-sensitivity Charcot's Triad as a screening tool.
Second, quickly and accurately classify the severity using the TG22 criteria. Remember, grade 1, mild, gets medical therapy first, watch closely. Grade 2, moderate, requires early drainage, aiming for that 48 to 72-hour window. And grade 3, severe, demands urgent drainage, ideally within 12 hours alongside full intensive supportive care.
Third, hit them immediately within the hour with broad-spectrum IV antibiotics. You absolutely must cover the common gram-negatives like E. coli and Klebsiella, but don't forget to account for enterococci species, especially in recurrent or healthcare-associated cases. And critically, tailor that initial regimen immediately for MDRO risk factors. Don't hesitate to use carbapenems if the patient profile local resistance patterns warrant it.
And fourth, and maybe most importantly, execute timely source control. The data is crystal clear. Achieving drainage, usually via ERCP, within that crucial 48 to 72-hour window for moderate disease significantly reduces mortality and organ failure. This really underscores that core hospital medicine dictum: stabilize, sterilize, and decompress. And remember, the key evidence supporting this rapid approach, particularly looking at outcomes and the timing of ERCP in relation to mortality, was powerfully demonstrated in that Schwed et al. Article published in JAMA Surgery back in 2016, a pivotal paper.
Absolutely. So our final provocative thought for you, the listener, to consider as you manage these complex patients, given the critical nature of getting empiric therapy right up front, and the rapidly rising prevalence of MDROs with significant variability in resistance patterns between different hospitals and even different units. How should our standardized protocols better integrate real-time local hospital antibiograms and resistance data? How can we use that local data to more intelligently guide the initial empiric antibiotic choice, specifically for these high-risk cholangitis patients?
That's a great question.
It really points toward a future where highly personalized antimicrobial management, driven by dynamic local epidemiology, will likely be essential to optimize outcomes in these emergent, time-critical scenarios. We need smarter, faster ways to pick the right drug the first time.
Definitely food for thought. Thank you for joining us for this deep dive on ascending cholangitis. We really hope this roadmap helps you tackle this critical emergency with more confidence and speed.